Then you have lymphadenopathy. Okay, one of the very important topics, as I told you, the nightmare has become true. Lymphadenopathy. So what about lymphadenopathy? First, you need to say when you call it as significant lymphadenopathy, because many times you can palpate very small nodes and they may not be significant at all. By definition, understand any palpable nodes except in the submandibular region and in the inguinal region. Anywhere else, if you palpate a node, it is likely to be significant. In the sense, some problem is going on. Only in the tonsillar area, okay, submandibular area, and maybe in the inguinal region, some few palpable nodes are okay. But any palpable nodes anywhere, okay, apart from these areas are considered to be significant, basically, number one. But if you want to have a very objective definition, so they say like if you have more than 1 centimeter lymph node in a cervical region, anything more than 1 centimeter in the cervical region, or if it's more than 1.5 to 2 centimeter, this is given different definitions, different textbooks, but I would say inguinal you always keep a higher cutoff. In the inguinal region, they are considered to be very significant. Cervical more than 1 centimeter or inguinal more than 1.5 to 2 centimeter, I will keep a higher cutoff for inguinal generally, 2 centimeter. So that's considered to be significant. And epitrochlear nodes, I don't know how many of you have known epitrochlear nodes. It's near the olecranon process. It's here. So you need to examine here. You have to roll your fingers down the olecranon process. So then only you can feel the epitrochlear nodes. But normally you won't feel, don't touch and see, and you will be disappointed. And why I'm telling is epitrochlear nodes are popliteal nodes in the popliteal fossa or supraclavicular nodes. So you can see in the left as well as right supraclavicular fossa of any size is significant. That's why I told you if you are able to palpate these nodes, it's significant. That's why if you are able to see that nodes, you might have one of HIV or syphilis or some random disease. Okay. Epitrochlear, popliteal or supraclavicular nodes of any size are supposed to be significant. Axillary, you can keep a cutoff of 1 centimeter again for axillary nodes also. But in general, apart from this tonsils and the inguinal region, any palpable lymph nodes, you need to be little cautious in clinical setting at least. It can be significant. We don't know. Okay, then when you call, okay, significance is fine. Now significance is understood. When you call it as a generalized lymphadenopathy, because there is another definition called significant, okay, we have generalized versus localized lymphadenopathy. So when we call it as a generalized lymphadenopathy, when the patient is having at least 2 non-contiguous areas that are involved. I'll say the lymph node areas first, then you can assess yourself. The major lymph node areas are head and neck areas, then axillary, then inguinal. These are the major head and neck. Almost 50% of the palpable nodes are present in the head and neck only. More than 50% of the palpable nodes in the body are present in the head and neck, and overall around 30 to 35% of the nodes in the entire body is located in the head and neck. That's why head and neck is very important. That's why most commonly majority of the lymphomas also affect the cervical nodes. So head and neck contributes to almost 1/3 of the entire lymphatic system, or it contributes to more than 50% of the palpable nodes. That's why your examination is never complete without head and neck lymph node examination. Okay, so if it's at least head and neck is one area you can consider, then axillary, inguinal. So if you have at least 2 non-contiguous areas that are involved, means you can call it as generalized lymphadenopathy. Localized means only one area is involved. So if it's only one area that is involved, means we are going to call it as localized lymphadenopathy. One focal group is involved. So then we have definition of persistent lymphadenopathy versus non-persistent. So what is the definition of persistent lymphadenopathy? The lymphadenopathy persists for more than or equal to 3 months. That is called persistent lymphadenopathy. If it persists for at least 3 months or more. So HIV is very common disease to produce a persistent generalized lymphadenopathy. Now you know what is the definition of persistent, what is the definition of generalized also. Okay, now coming to the concept of palpable nodes. What are the concept of palpable nodes? What are the nodes that are palpable? Basically head and neck. The most important, I told you 50% plus palpable nodes are located in the head and neck only. These are actually palpable nodes. Then you have axillary nodes, which are palpable. Then you have inguinal nodes, which are palpable. Technically speaking, these are the most common palpable nodes. Other nodes, practically speaking, it has no value in palpation. These are the nodes that you can ideally find out through palpation. Other nodes have no clinical value if you are going to find out by palpation. But please understand, your examination is never ever complete without spleen examination, because spleen is a very important lymphatic structure. So whenever you are asked or something, if examiner is asking you to palpate for lymph nodes, never complete your examination without looking for the spleen size. That's a major blunder you do. If it's an ASCII, if it's a 10-mark ASCII, and you're not examining spleen, they'll give only 5 marks. That too, grace marks, 5. If I'm the examiner, I'll not give even 2 marks also, if you don't see for the spleen, because it's a very, very important lymphatic structure, and isolated splenomegaly can be seen in many lymphomas. That's why you need to look for that. For example, CML, you will not have any lymphadenopathy, only splenomegaly will be there. Hairy cell leukemia, you will not have any lymphadenopathy, only splenomegaly will be there. That's why this is very important. You can see isolated splenomegaly in multiple lymphomas and multiple hematopoietic malignancies. Okay. Plus, if it's required, okay, you can look for epitrochlear and popliteal nodes also. Popliteal nodes, but that's only an option depending on a local process, depending on what your hospital examiner wants. If they expect, then you can palpate epitrochlear and popliteal, but I will not bother if the student doesn't examine, because they are very rare to have. Plus, even if you find those things, the causes again go to the same, like set of causes. It's not going to alter your management. Conditions that produce generalized lymphadenopathy only will produce epitrochlear and popliteal nodes also. So it's very unlikely to have an isolated epitrochlear or popliteal lymphadenopathy. But your oldies will expect 2 more lymph nodes to be palpated also, that is para-aortic. I really don't understand how they can palpate para-aortic. Ideally, by deep palpation of the abdomen, you can palpate. So on both sides of the umbilicus, little bit in the upper quadrant, you can palpate para-aortic lymph nodes on both the sides. Technically, if they ask you how to palpate para-aortic nodes, by deep palpation. For this, patient should be very thin. Patient should have a scaphoid abdomen, very malnourished patient, having a big cancer with big metastasis to the para-aortic nodes, then only you can palpate para-aortic lymph nodes. But I don't know whether how much it's technically possible. But they might expect this. Or even some examiners may be very nonsensical, asking for mesenteric lymph nodes to be palpated. Okay, theoretically it can be palpated in children, especially children. Mesenteric lymphadenopathy is very, very common. Mesenteric lymphadenitis. Adults, technically speaking, typhoid can produce mesenteric lymphadenitis. TB can produce mesenteric lymphadenitis. Crohn's disease can produce small mesenteric lymphadenitis. So mesenteric lymph node, again, to examine, you need to have a very, very thin patient. That's common only in pediatric. Nowadays, pediatric patients are also very busu. So it's very difficult to, examine them also. Very thin pediatric, patient. If it's a significant mesenteric lymphadenitis, you can probably, I don't know, I'm not sure, somebody who have examined and felt as a lymph node, 90% of the times it will be not a lymph node, something else. But they will think it's a lymph node. That's what is going to happen. So how you will palpate mesenteric lymph node? Because the attachment of line of mesentery is towards the McBurney's line, from the umbilicus towards the right iliac fossa. So that is the point of palpation for mesenteric nodes. If they ask you, that's only theory. So if they ask you how will you palpate mesenteric node, you have to palpate from the right iliac fossa to the umbilicus, called McBurney's line. McBurney's point is from the proximal and the distal, proximal 2/3 and distal 1/3 junction is McBurney's point. McBurney's line is from the RAF to the umbilicus. So along the line, that is the attachment of the mesentery, basically. So on that line also, you can look for mesenteric nodes palpating in that area. So para-aortic only in deep palpation. But logically speaking, as an examiner, as a modern examiner, I'll expect only these 3. Okay. So if I ask a lymph node examination, go for those 3: head and neck, axilla, inguinal, and spleen. Enough. That's it done. I'm okay with that. And whenever you are whenever you are palpating a node, what are the things you are looking for? What are the things you're looking for in a lymph node? Number one, of course, the size. Okay. So remember, there is a rule. The larger the size, the higher risk of malignancy. That's all. Bigger the size, higher is the risk of malignancy. Especially for Western countries. In India, TB is very, very common. It's there left, right, everywhere. More than COVID, we see TB everywhere. So TB is a very important cause. But the larger the node, the general consensus, there is high risk of malignancy or a granulomatous disease like TB. So you should always think about those possibilities. Size is very, very important. Second is the pain. Pain indicates it's a likely inflammatory condition. But again, it's not very specific. But pain generally tells it's an inflammatory etiology rather than malignant etiology. If it's a very tender node, you can think about inflammatory etiology, because classically metastatic nodes will be non-tender, hard, and immobile. It will be fixed. This is a classic description of a metastatic node. Then third, it could be the consistency is what you need to look for. So consistency, ideally, normal lymph node will be a little soft to firm. Okay, not soft, we can say, maybe little firm, a normal lymph node. But if it's stony hard, you're going to think about what? Metastasis, basically. But firm and rubbery, where you will see? Classically in Hodgkin lymphoma. That's what they describe, but you need to answer that. Firm and rubbery nodes, India rubber consistency. That's what they'll expect in exam. So that is suggestive of Hodgkin lymphoma. And if you have a soft fluctuant nodes, okay, very soft nodes, that indicates a inflammation, basically infection or inflammation. Very soft node, infection or inflammation. Okay, then you're going to look for fluctuation, fluctuant node. Fluctuant node means fluid is there, pus is there, so it indicates what? Infection, fluctuant nodes. There's another kind of consistency called buckshot consistency. Buckshot means, this is a Western terminology again. How to say? Maybe have you seen in small age and all, in your younger age, have you used that small pellets and that gun? Have anyone used that? Have you used that? That small pellets in exhibition and all they give, no? Even in home also we used to get that. But in home you can use only plastic. But in exhibition they'll give that metal. That's actually a buckshot to shoot the birds. They use that to traumatize the bird. So that's a buckshot. So if the consistency is very, very small node, but under the skin you're seeing this buckshot appearance. Okay, you can palpate that. Buckshot kind of nodes. It's very common in children. This buckshot node indicates a viral infection generally. It's common in children. Okay, indicates a viral infection. Then whenever you see conglomeration. So what do you mean by conglomeration? In Indian terminology, we can call it as what? Matting. Matting. But in Western terminology, it is conglomeration. Conglomerate nodes means multiple nodes are united together to form a single solid mass. So conglomeration or matting, remember, it can indicate a malignancy, but I don't know why Indian examiners always expect TB as the answer. Remember, granulomatous conditions also can produce conglomeration. One of the classic granulomatous disease is TB already. But remember, that malignancy also can produce conglomeration, and union of multiple nodes to form a single mass. So both are differential, but in India, always tell TB. When they tell matting, you tell TB. That's safe. They ask maybe more options, then probably you can answer granulomatous disorders. So then, one more important thing is supraclavicular nodes. Remember, they have the highest chance of being malignant. If they ask you which group of nodes has the highest chance of being malignant, if it's palpable, it's supraclavicular nodes. What is the chance of supraclavicular nodes being malignant? If depending on the age again. If age is more than 40, if you are able to palpate supraclavicular nodes, 90% it will be malignant. 90% malignant risk if age is more than 40, and 25% malignancy rate if age is less than 40. So age is a determinant factor number one, plus supraclavicular nodes finding itself is having a high risk of underlying malignancy. So if they ask you highest risk of underlying malignancy, which node group? Supraclavicular node. As I told you, left supraclavicular adenopathy, if you find it, that's also called as what? Troisier's sign. Periumbilical node, if you see, that is called as Sister Mary Joseph nodule. You would have studied in surgery itself. But Troisier's sign means there is a high risk of GI or pelvic malignancy, ovarian or a gastrointestinal malignancy. Very commonly, GI or ovarian malignancy. If it's a right supraclavicular node, it usually indicates the thoracic malignancy. So it's still GI can happen in left clavicular, and thoracic also can happen in left clavicular, and GI and thoracic can happen in right clavicular also. But classically speaking, left clavicular means it is GI and ovary. Right supraclavicular lymphadenopathy means it is very commonly a thoracic malignancy, very commonly a lung or a esophageal cancer. Okay, thoracic cancer, some thoracic cancer, very important is lung cancer. Right supraclavicular nodes. Left for GI and ovary, right for esophagus and lung. Okay, what are the characteristics that will tell you whether the lymph node is benign or if it is malignant or mycobacterial cause? So number one is the pain. Pain, benign means very commonly they will be tender to touch. Whereas malignant nodes or granulomatous nodes will be painless, non-tender. Generally, consistency will be soft, as I told you. Here, consistency will be hard, or at least more firmer in texture, or I can say stony hard or hard. So that will be the consistency. Fixation, it will be mobile nodes generally if it's a benign cause, whereas fixity will tell you that it's very likely to be a granulomatous or a malignant cause. Location, very often it will be cervical and inguinal. These are the classic areas for or suboccipital or submandibular. So the cervical in the head and neck area, very common, and inguinal region. But in the cervical region, anterior to sternocleidomastoid or posterior to sternocleidomastoid, which will tell you it's benign and malignant. Generally, anterior to sternocleidomastoid muscle is very likely to be benign. The same cervical nodes, if you see the nodes are posterior to sternocleidomastoid, it's very likely to be malignant or granulomatous at least, TB or something else, posterior to sternocleidomastoid muscle. And of course, finding of a supraclavicular node is having a higher chance of malignancy. Whereas progression, it will be an acute enlargement. Acutely, they will enlarge in size, but there will be no much progression. Suddenly, they will enlarge and they will remain the same, or they will become small faster. That's typical of inflammatory or benign cause. Whereas in malignant cause or mycobacterial cause or granulomatous cause, it will be a slow development, slow increase in size, or at least a subacute increase in size. That's what I'm trying to say. Slow doesn't mean it should take years or months. It's a very subacute increase in size, but it is progressive enlargement. It will keep growing. In a malignant or a mycobacterial cause. What are the conditions that produces painful? Generally, whenever you want to classify lymphadenopathy, you can say painful localized, painful generalized, painless localized, painless generalized. So what are the causes of painful localized lymphadenopathy? Some skin infections. Some skin infections can cause. Local pharyngitis can cause. Oral or genital herpes, some classic examples I'm saying. Oral or genital herpes can cause. Okay, there is a disease called cat scratch disease. Okay, remember, typically cat scratch disease will produce cervical or axillary lymphadenopathy, but it can produce anywhere depending on the cat scratch, which area the cat scratch is happening. Okay, cat scratch disease. Then chancroid, okay, Haemophilus ducrei infection can cause painful lymph nodes. Then Kawasaki disease. Which group of nodes will be affected in Kawasaki? Typical question, NEET exam especially. In children, cervical unilateral, very classic in Kawasaki. It will produce cervical nodes, that too on the unilateral, one side only. Bilateral nodes are very uncommon in Kawasaki. Kawasaki disease. Then infectious mononucleosis, they produce bilateral cervical. That's why it's important. DD. Kawasaki will produce unilateral cervical involvement, whereas infectious mononucleosis will produce bilateral cervical involvement. And your rubella, these are very classic examiners questions. So rubella, where it will produce enlargement. Typical post-auricular region, very typical. You would have studied in your SPM as well as in your pediatrics textbooks. Rubella typically rubella is also called as what? German measles or 3-day measles. The original measles is called as 14-day measles. That is measles. Okay, rubella is also called as German measles or 3-day measles. That typically tend to produce post-auricular lymphadenopathy, very characteristic. And mumps also can produce some local lymphadenopathy. Obviously, in all the situation, lymph node will be very tender. And generalized lymphadenopathy, very common in viral infections. Viral infections like cytomegalovirus, HIV, all the MMR viruses. What are the MMR? Don't see it as a vaccine. MMR means I tell about what? Measles, mumps, rubella. Okay. MMR stands for these viruses only. If you write MMR vaccine only, it becomes what? Vaccine. All the MMR viruses and chickenpox, varicella also can produce a generalized painful lymphadenopathy. Very small lymph nodes throughout the body can be there. And certain bacterial infections can cause this. What bacterial infections? Listeria, brucella. Brucellosis is very, very important. And syphilis can cause generalized lymphadenopathy. But even though syphilis can also produce what? Local painless lymphadenopathy. Or local painful lymphadenopathy in your inguinal region, possible. And then you can see in parasitic infections. What parasitic infections? Malaria, schistosoma infections, toxoplasma. So, but in our country, malaria and toxoplasma is very important. But apart from that, visceral leishmaniasis, it's very common in north and northeastern states in India. Leishmaniasis, visceral leishmaniasis, Kala-Azar. So these situations can produce generalized painful lymphadenopathy. What are the conditions that produces painless lymphadenopathy? Local, obviously granulomatous conditions like TB and sarcoidosis. Obviously, what is that? Malignancy, metastasis. Metastasis also tend to produce localized painless lymphadenopathy. And third, probably I can say connective tissue disorders, especially rheumatoid arthritis and SLE. You'll be wondering whether they produce localized or generalized. Usually rheumatoid arthritis and SLE tend to produce localized cervical lymphadenopathy only, very commonly. They'll not produce generalized lymphadenopathy. Painless generalized causes, of course, malignancy, but here we are talking about hematological malignancies like Hodgkin or a non-Hodgkin lymphoma. Okay, can produce generalized lymphadenopathy throughout the body. But metastatic lesions from solid organ cancer will involve only localized nodes generally. Then autoimmune disorders, especially Sjogren syndrome. As I told you, RA and SLE are known to produce localized nodes, but whereas Sjogren syndrome is known to produce generalized lymphadenopathy. Then we have multiple other conditions like lysosomal storage disorders. Certain lysosomal storage disorders like Gaucher disease, Fabry disease, Niemann-Pick disease can produce generalized lymphadenopathy along with hepatosplenomegaly they produce. Okay, so Gaucher, Niemann-Pick, and Fabry disease, very classic examples. Then patients are having hyperthyroidism. Apart from lysosomal storage disease, hyperthyroidism, amyloidosis. Once again, sarcoidosis, granulomatous condition of sarcoidosis can produce generalized lymph node also. You cannot predict. Even TB can produce generalized lymph node also. Granulomatous conditions. You cannot pick up. So if you want to put into a table form, this is how you can put into a table form. Depending on whether it's painful localized or painful generalized or painless localized or painless generalized. But anything, so wide causes are there. So many causes of lymphadenopathy are there. Okay, this picture I have given to understand, like important areas. If it's involved, what are the important things? First, no need to know this. It's very, easy to understand. So any submandibular node, you have to think about tonsillitis. That's very classic cause, or infections of the oral cavity, like pharyngitis, or it can be a malignancy of the oral cavity. If it's a cervical node, infection of the upper respiratory tract, infectious mononucleus, I told you bilateral cervical, Kawasaki I told unilateral cervical, or malignancies of the head and neck area. Simple, isn't it? Or right supraclavicular nodes means obviously you are going to discuss about the malignancies of the thorax. Okay, similarly, if it's a left supraclavicular node means you are going to think about malignancy. That's also called as Virchow's nodes. Troisier sign. It's also called as Virchow's nodes. So if that is the case, then it's a GI malignancy or ovarian malignancy. With superficial inguinal lymph node means, number one, I'm going to think about STD. Depending on what group is involved, whether it's vertical group or horizontal group, I'll talk about that later on. So first is STD, Emephilus ducreis, syphilis, lymphogranuloma venereum. So any disease can produce superficial inguinal lymph nodes. And malignancy of the pelvis or genital tract. Okay, malignancy of the genital tract can produce this. Infections of the leg can produce your inguinal lymphadenopathy, and cellulitis of the foot also can result in inguinal nodes. Axillary lymph nodes, obviously the most important for exams is going to be breast cancer. You need to definitely examine for that. Mastitis, a benign condition, and infections of the arm also can result in axillary nodes. Epitrochlear nodes, always significant. So it is something, anything that produces generalized nodes can produce epitrochlear nodes. Similarly, Sister Mary Joseph node is always a sign of stomach malignancy. And popliteal lymph node, once again, it's very significant, but it can be of any cause. Okay, so these are some important areas where you need to know. And this is a picture, I think, you have video separately. I'll show the video. So how to examine. So first of all, if you see, you're having 4 group of nodes. I mean, the major palpable nodes are these. These are the head and neck nodes. Then you have the axillary nodes, and you have what? Inguinal nodes. So these are the major palpable nodes. In that, the head and neck alone, the 3 dots alone contribute to more than 50% of the palpable nodes. And then as you move to the palpable nodes of the head and neck. So what are the nodes that you can palpate? Suboccipital. Then you can palpate the preauricular and postauricular nodes. Then you can palpate the submandibular nodes. Then submental nodes now. Then you can palpate the posterior cervical nodes. Apart from posterior cervical, this group are called as deep cervical nodes. That is along the sternocleidomastoid, both anterior and posterior to the sternocleidomastoid. And finally, you should not forget the supraclavicular nodes. Supraclavicular nodes ideally will come under the head and neck zone only. And that deep cervical nodes are basically under class 2, 3, 4. I'll talk about that later on. And this is how you examine a suboccipital node. This is postauricular, this is preauricular, and this is submandibular. This is deep cervical nodes, anterior to sternocleidomastoid, and this deep cervical nodes posterior to the sternocleidomastoid. And you are going to examine the supraclavicular nodes and the infraclavicular nodes also. Infraclavicular are also called as subclavicular nodes. Then systematically you have to go to the axillary nodes. In the axilla, you have multiple groups. First group is anterior group, or otherwise called as pectoral group. Along the pectoralis major muscle or minor muscle, not major actually, pectoralis group. Anterior group, where the lymphatic substrate from the breast will come. And you have the posterior group, where the lymphatics will come from the arms. Little bit from the arms will come. And you have the lateral group. Lateral group, the main supply is from the arms. And all these 3 groups, anterior, posterior, and lateral, is going to drain into central group. And then this central group will drain into the subclavicular group. In the last examination, we saw infraclavicular nodes that we completed in the head and neck examination itself. So central group will then go to the subclavicular group. The infraclavicular nodes basically are along the subclavian vein, below the clavicle. So now he is examining the anterior group, then moving on to the central group, then moving on to the posterior group. Okay, this is central group again. Then as you go to the humerus proximal end, you can see the lateral group also. So generally, if you're not sure whether it's a lymph node or not, ask the patient to relax the arm. Put the arm down. Now you'll be able to feel the lymph node better. In the, you can see this is anterior group, as he said. Okay. Now going to the central group. Then going towards the posterior group. Then in the humerus, proximal end of humerus in the arm, you are going to examine for the lateral group. Now if you're not able to feel the node, or if you're suspicious for a node, or if you're not knowing whether it's a node really or not, then you need to put the arm down, because in a relaxed position, you will be able to see the nodes better. You will not feel the nodes better. That's why final examination should be complete by relaxing the arm down. Then coming to Ingle nodes, I told you there are two groups of Ingle nodes. One is called horizontal group and second one is vertical group. Horizontal group will be located along the inguinal ligament, as you can see here, and vertical group is located along the great saphenous vein. It's placed vertically. The horizontal group will receive lymphatic drainage from the genitals and the lower part of the abdomen. And vertical group will be placed along the great saphenous vein and will be receiving lymphatics from the leg. That's why I told you, depending on which group is involved, you can say what is the area of pathology. If more of vertical group means now is examining the horizontal group. Horizontal group will be along the inguinal ligament. So you have to palpate parallel to the inguinal ligament. With horizontal group means the problem is the genitals or in the lower abdomen. Vertical group enlargement means some infection of the leg like cellulitis can cause vertical group enlargement. And again, as I told you, the examination is not complete without what? Spleen examination. Spleen is involved in almost more than almost 1/3 to 2/3 of the hematological malignancies. So you should never ignore spleen. So because spleen is in the left subcostal area, and what is the direction of enlargement of spleen? It's towards the umbilicus. It never enlarges down because of multiple ligaments that prevent the enlargement of the spleen downwards. So the spleen ideally enlarges towards the umbilicus and towards the right iliac fossa. So the direction of spleen enlargement will be like that, diagonally, towards the umbilicus and into the right iliac fossa. That's why whenever you examine a spleen, you should start if there is an obvious splenomegaly, if you suspect, then you have to start the examination from the right iliac fossa towards the umbilicus and move towards the left costal margin. So spleen examination should always start from the right iliac fossa. Because if it's a massive splenomegaly, crossing the umbilicus means if you examine the subcostal margin straight away, you will miss out the spleen. Because you will not see anything. Because spleen has gone past what? Right iliac fossa, and everything will look uniform. You will be missing out the spleen. That's why start from the right iliac fossa, go towards umbilicus and then towards the left subcostal margin. So that's what he's doing. He is going from right iliac fossa towards the umbilicus and going towards the left subcostal margin. And if you're not still able to palpate the splenic tip or splenic notch, then you can ask the patient to breathe deeper, because spleen is an organ that moves with breathing. And you can insinuate the fingers under the left subcostal margin like this. So you'll be able to feel the spleen better. Clear not? So easy to palpate spleen basically if you have expertise. Very easy to palpate. Okay, you can at least palpate the splenic notch if it is enlarged, or at least the tip of the spleen should be palpable. If the tip of the spleen is palpable, it is normal. Please understand, it's not an enlarged spleen. In even a normal thin individuals itself, tip of the spleen may be palpable. So that does not tell you any abnormality. Okay, so only when the spleen is grossly palpable, it is splenomegaly, technically speaking. Okay, I'll talk more about splenomegaly in GIT. Do you understand this? How to examine for lymphadenopathy? Okay. So how can I remember the causes of lymphadenopathy? Causes typically I used to remember by a mnemonic called Miami. Miami is a mnemonic. Miami is a state in US, place in US. So what M stands for? M stands for malignancy or METS. If you're not able to remember everything, at least remember this. I stands for what? Infection. Almost every single infection can cause lymphadenopathy. Bacterial, viral, fungal, parasitic, and even rickettsial infections can produce lymphadenopathy. Then A stands for autoimmune cause. As I told you, SLE, rheumatoid arthritis, Sjogren's syndrome, even adult onset Still's disease. There's something called AOSD, dermatomyositis. Many CDDs can cause lymphadenopathy. Then you have miscellaneous or unusual causes. What are the unusual causes? You have something called Kikuchi-Fujimoto disease. That's called Kikuchi disease or Kikuchi-Fujimoto disease. It's very common in young girls, generally in the 20s. They tend to have cervical lymphadenopathy, and in biopsy, you will have necrotizing lymphadenitis. And histiocyte proliferation will be there. Along with it, there will be necrotization, necrosis will be there in many areas in histology. And these girls generally recover, but they have a future risk of SLE. You have to monitor with the ANA. That's Kikuchi disease. India also is actually quite common, but we don't look for, because this is a lymphadenopathy that comes and goes. So many people may not be even aware of, but it will be a big lymphadenopathy. Patient will have fever and associated inflammatory symptoms. Cervical lymph node, histology will show necrosis and little histiocyte proliferation. And these individuals are at risk of developing future systemic lupus erythematosus, Kikuchi-Fujimoto disease. Or we have something called as Kimura disease. These are very rare and unusual disease. And we have something called Castleman disease. Again, discussion of all these disorders are beyond the scope of the current discussion. And Rosai-Dorfman disease is there, or any other condition that produces histiocytosis. Histiocytosis can result in lymphadenopathy. Very rare and unusual causes. Please don't say this unless and until the examiner asks for other causes. So, but the problem is, our brain will think about unusual causes only in exams. Suddenly, if the examiner asks about cervical lymphadenopathy, student will answer Kikuchi disease. Examiner will feel like acid slapping you on spot. But you will give a very, like Pavam expression. You'll be like this in exam. Isn't it? So you will be like, what mistake I did? It's a cause of lymphadenopathy only. Outside, you'll go and tell your friends. So Kikuchi sir told it's a cause. It's given in the book also. Then why examiner is scolding? Any patient in front of you will think first Kikuchi. Huh? So don't behave smart, okay? Don't say this unless and until it's asked for. Iatrogenic causes are there. So iatrogenic causes means medication. Some medications can cause lymphadenopathy. Most important are phenytoin and allopurinol. Phenytoin and allopurinol. I think in pharmacology there is one. I studied in Tirupati when I was studying. There is something called as one syndrome is there. I mean, for everything they will name a syndrome that is different. But this lymphadenopathy itself has some name. Anyone knows? In pharmacology, I think. In phenytoin, pseudolymphoma. Got it. So phenytoin-induced lymphadenopathy. The other name for that is called as pseudolymphoma. Actually, I studied this in KD Tirupati only. Only KD Tirupati gives these kind of things and all. But the best book ever studied is Katzeng and Trevor only. It's the best book actually for pharmacology. But unfortunately, I read only 50% of Katzeng and Trevor because I didn't have time, as many people say, because I had time for movies and other things, but I didn't have time to read. Basically, to be honest. So that's how you need to substantiate that you don't have time. Isn't it? Still, like I did watch a lot of movies. Okay. I'm a big movie fan actually. I watch every single movie. Even during the time of KMC, unfortunately, our Kilpak Medical College is surrounded with so many, so many things. So left side of Kilpak Medical College, if you go, there will be Iga Theatre. Right side, within walking distance, you'll have Sangam Theatre. Behind, you will have Chetpat Lake where you can go swimming and you can go boating with your girlfriend. Okay. And there are a lot of hiding places, to be honest, in Kilpak Medical College. Lot of trees, lot of greeneries, lot of bushes. Like lot of places are there. And there are many unmanned places are there in Kilpak Medical College. So especially abandoned hostels are there. Okay, these are old hostels where no manning will be there, nobody will be there. And they demolished now and they re-established, which actually broken the hearts of many juniors. Actually, those hostels, they're saying, we don't want extra hostel. You don't reconstruct, you leave that. They're saying, but unfortunately, like Dean is thinking in the other way. They created new girls hostel, which they are never interested in. Okay. So then we have, I think Satyam Theatre is one of the famous theatres there, just behind the Kilpak Medical College. So many restaurants, because Kilpak is the central area, Kilpak, Anna Nagar central areas in Chennai. So it's very difficult to read actually in Kilpak Medical College. So the students never read there. I don't know about here, what location things are situated. Your colleges? Same. So many theatres, so many malls, so many hiding places. Okay. Okay, I've seen actually, I've asked one of my juniors. So he was telling like one girl and boy was missing. And he's telling I'm playing hide and seek. And the thing is, like, he's hiding in the, like lower part of the stairs, and the girl is hiding in the upper part of the stair. I don't understand what hide and seek is that. Okay, cool. So thing is, I think recording is also going on, so I cannot say much, honestly. Okay, I think many of you would have played hide and seek. Like, many guys are having good idea, but see, he's explaining very vigorously, like, this is how you have to play hide and seek in the hospitals. See, that's why you don't want to remove his mask also. You want to show his face. Okay, now we showed. Okay. So, medications, phenytoin and allopurinol. And seriously, in medical orders, I have seen, like, there are many potential Johnnisons in medical college, but that potential is not coming out. I don't know why. Many potential Johnnisons are there in medical colleges. That unfortunately, because of our social inhibitions, that potential is not transforming into action. Probably. They're keeping their action to themselves, I think. That's why. I don't know why. So, see, a lot of Johnnisons are hiding within you. See, Johnnisons is a very big shot. See, yeah, he's a very big shot and he knows everything, man. I mean, he's a plumber, he's a doctor, he's a staff nurse, he's a carpenter. And he plays badminton, he plays tennis. What he doesn't know, what I understood is that you don't know Johnnisons. You cannot be without knowing the legend. Okay, sir, fine. So you have to know the legend. You know who Johnnisons? No. I can see from your face. You don't know who Johnnisons is. Okay. Okay, cool. So this is the Miami mnemonic. Okay, so phenytoin and allopurinol. I don't know how the topic went there. I don't even understand. From phenytoin to Johnnisons. That's a huge transformation and jump. Okay, it's fine. Allopurinol, then you can get with gold. Okay, you can get with hydralazine. And sulfonamides, quinidine. I don't know. The list goes on. List keeps going on, but I'm not sure what is important. But if at all, if you want to say maybe phenytoin, allopurinol may be important to some extent. Okay. Phenytoin, allopurinol. Iatrogenic cause. Okay, typically due to medication. So you can put all the causes in this 5. Okay, Miami: malignancy, metastasis, infections, autoimmune, unusual rare causes, or like miscellaneous unusual rare causes, and finally are iatrogenic cause, especially due to medications. You can put everything under this. Okay, all the lymphadenopathy. And you have something called syndromic approach. This is very, very favorite question of examiners. Syndrome associated lymphadenopathy, syndromic approach. So first syndrome is infectious mononucleosis-like syndrome, or simply called as mononucleosis-like syndrome. Or it's not IM like, it's mononucleosis-like syndrome. So what you will get in mononucleosis syndrome? You will have fever, you will have fatigue, you will have malaise, sense of not so feeling good. That's malaise, isn't it? Loss of well-being. And patients will have very high number of atypical lymphocytes in the peripheral smear. Atypical lymphocytes in the peripheral smear. Okay, so this is typical mononucleosis syndromes. And only I'm telling about the classical causes described in literature. But lymphomas also can cause this picture. But I'm talking about classical conditions that's been described in literature that causes mononucleosis-like syndromes. The typical example is infectious mononucleosis itself, number 1. That is due to Epstein-Barr virus, as we all know. It can be due to Toxoplasma gondii, that is toxoplasmosis, or it can be due to cytomegalovirus infection, or it can be due to acute HIV infection, that's called as acute retroviral syndrome. There's a name given to that, acute retroviral syndrome. 10% of the patients who have been infected with HIV develop this acute HIV syndrome or acute retroviral syndrome. And acute HBV can cause this. Acute hepatitis B virus, because of serum sickness, they can get something like that. HBV is known to cause serum sickness. Everyone knows that. And streptococcal pharyngitis, simple streptococcal pharyngitis also can produce this kind of picture. It's very classic. This is called mononucleosis-like syndrome. Second is something called as ulceroglandular syndrome. Ulceroglandular syndrome. So technically, you will see a skin lesion here. Okay, you will have a skin ulcer or a skin lesion. Along with that, you will have lymphadenopathy. Okay, so this is ulceroglandular syndrome. I think I need to write there, not here. Okay, I have written here syndromes. Ulceroglandular syndrome. So here also you'll have lymphadenopathy, all right. In ulceroglandular syndrome, you'll have a skin lesion, ulcer, typically, plus a lymphadenopathy. So, which is the classic disease which is called as ulceroglandular syndrome or ulceroglandular fever? Have you ever heard of something called as tularemia, caused by Francisella tularensis? And the treatment of choice you have studied and mugged up in pharmacology, that is streptomycin. Remember? Okay, tularemia. That can result in, this is a typical example, classical of, that's actually called as ulceroglandular disease, tularemia, other name for that. Apart from that, impetigo, that is, impetigo is generally caused by whom? Which organism? Who causes impetigo? Streptococcus pyogenes, group A beta hemolytic streptococcus. Or it can happen with cat scratch disease. Then it can happen with Lyme disease, Borrelia burgdorferi, okay? Lyme's disease, you can see with this. So Lyme's disease can be the case. Okay, so this is ulceroglandular syndrome. Then third, we have something called oculoglandular syndrome. Oculoglandular. So what is oculoglandular? Patient will have conjunctivitis with lymphadenopathy. Typically a preauricular lymphadenopathy. That's called oculoglandular syndrome. The characteristic example is viral conjunctivitis. Viral conjunctivitis, it could be keratoconjunctivitis also. In the sense, it could be either keratitis or conjunctivitis or both. Viral keratoconjunctivitis, or it can happen in cat scratch disease. Cat scratch can cause both ulceroglandular as well as oculoglandular syndrome, depending on which area the cat is scratching or licking. Okay, oculoglandular disease or oculoglandular syndrome. So this is different syndromes associated with, traditional syndromes that is associated with lymphadenopathy, clinically important. So this is the different levels. Again, all these are very important. They can go into this discussion also. At least at an undergrad level, you need to know that what is class 1A or 1A, group 1A nodes, submental nodes. Okay. 1B, the location itself says, isn't it? This is submandibular nodes. 1B is submandibular. 1A is submental nodes. So how will you say whether it's 1A or 1B? Depending on the anatomical location. So you can see you have the midline here, okay, or not a midline. You can see this is anterior belly of digastric, okay, and you have the posterior belly of digastric here. This is the posterior belly of digastric. So the region in the between the anterior belly of digastric is what we call what? Submental nodes. The region between the anterior and the posterior belly of digastric is what we called as what? Submandibular nodes. Anatomically, the region between the two anterior belly of digastric we call submental, and the region between the anterior and the posterior belly of digastric typically comes under what? Submandibular nodes. This is level 1B or group 1B. What is level 2 nodes? Remember, level 2, 3 and 4 all are called as deep cervical nodes. They're all called as deep cervical nodes. They can be anterior to sternocleidomastoid as well as what? Posterior to sternocleidomastoid. Okay. So 2, ideally speaking, what is the anatomical location of 2? So you have the attachment of sternocleidomastoid on the top until the level of hyoid bone. Okay, that is level 2. Till the level of hyoid bone, that is level 2 anatomically. From the hyoid bone till the level of cricoid cartilage along the sternocleidomastoid. Again, I'm talking about along the sternocleidomastoid. Till the cricoid cartilage, it is what? It is the level 3. And below the cricoid cartilage up to the clavicular attachment of sternocleidomastoid, it is level 4 nodes. Till the clavicular attachment of the sternocleidomastoid, it is level 4 nodes. Please understand, your supraclavicular nodes, or otherwise called as Virchow's nodes, will come under level 4 nodes. That's a very important point. Supraclavicular nodes, we are talking about Virchow's nodes, isn't it? The right and left supraclavicular nodes. Left is Virchow, but anyway, the supraclavicular nodes will come under what? Level 4 nodes. Then you have 5. Typically, 5 is a posterior nodes, posterior group. posterior group. Posterior nodes are level 5 nodes. In that itself, we have 5A, 5B. It's not that important, which means posterior group means the nodes are posterior to sternocleidomastoid. Okay, so typically speaking, they are between the trapezius and the sternocleidomastoid. Okay, that is the posterior triangle. I mean, so you know the posterior triangle, isn't it? Top, you will have the confluence of your sternocleidomastoid and trapezius, and below you will have the clavicle inferior. So that forms the posterior triangle here. So, or anything posterior to the sternocleidomastoid is posterior triangle. So posterior triangle nodes or posterior lymph nodes, posterior group nodes. And finally, you have the group 6. Group 6 are called as anterior group. Anterior nodes. In that you have pretracheal, paratracheal, prelaryngeal. Okay, so that is 6 nodes. Pretracheal, prelaryngeal, and paratracheal nodes. All these will come under level 6 nodes. Okay, let us see some of the named nodes. So if I say jugulo-digastric, or deep cervical nodes are also called as jugular group, okay, because they run along the internal jugular vein. That's why they are also called as jugular group. So, which means jugulo-digastric means it should be along the jugular vein and sternocleidomastoid. That is one of the 2-3 nodes, which is closer to the digastric muscle. 2, 3, or 4. 2, 3, or 4. 2, obviously. So, jugulo-digastric node will come under what? Level 2 nodes. Okay. Then we have jugulo-omohyoid. That's another named node. It will come under which group? Level 3. Jugulo-omohyoid. They'll come under level 3. Obviously, level 4, the importance is supraarticular nodes will come under level 4. And in level 6, one important named node is that's called Delphian node. So what is Delphian node? That is a prelaryngeal node. It's a prelaryngeal node. Okay, Delphian nodes. Remember, in the head and neck examination itself, see, I told you only the neck nodes, but in this diagram, you don't have what? Occipital nodes. You don't have the preauricular and the postauricular nodes, and we have not included the subclavicular nodes. Subclavicular nodes or infraclavicular nodes run along the subclavian vein. Okay, under the clavicle. Do you understand or not? Very important. All these other nodes also. Whenever during head and neck, suboccipital, preauricular, postauricular and preauricular, all the neck nodes. Along with that, don't forget the infraclavicular nodes. So all these examination will come under the head and neck lymph node examination only. Then go to the axillary group. Then go to the inguinal group. Then if you want, then definitely the spleen. If you want, you can examine popliteal and epitrochlear. If you still want, you can go for para-aortic and your mesenteric lymphadenopathy. Okay, that completes our discussion on lymphadenopathy. No. Approach to lymphadenopathy is there. That's why I think I left this table. How will you basically approach a lymphadenopathy? So, practically speaking, first, you do a proper clinical examination. Proper clinical examination. So, in the clinical examination itself, most of the times you will be able to achieve a diagnosis. For example, patient is having pharyngitis and related lymph node in the cervical region. It is very simple. Or the patient is having tonsillitis and submandibular node. So, simple. Pharyngitis and submandibular node, simple. Ear infection and preauricular node, simple. So, you know, clinical examinations can give you a diagnosis most of the time, or some basic investigations itself can give you a diagnosis. So, if diagnosis is established, then start treatment based on that, whether you want to treat or not. In this situation, you are having a suspected diagnosis, in the sense you don't know clear cut that this is the cause, but you are suspecting something could be the cause. So, you can run the investigations based on that suspected cause. The thing about infectious mononucleosis, go for monospot test, isn't it? For EBV. So, if you think about CMV, do an anti-CMV IgM. If you think about toxoplasma, do a toxoplasma testing. So, depending on, or if you think about a TB, do a biopsy, whatever. So, you do suspected testing and targeted testing depending on what you are suspecting. So, depending on the testing, you can either achieve a diagnosis where you can start the treatment based on your diagnosis, or if you don't have a diagnosis, even after testing, you may not have a diagnosis, even after testing. These group of patients are patients who who you don't have any clues at all, unknown origin, can we put under the same condition? So after testing, if the diagnosis is not understandable, or if you think the lymphadenopathy is of unknown origin, which means that patient should never get lymphadenopathy in that area, but still they are getting. So in this situation, now the next question is whether you are suspecting any malignancy or not, based on the risk factors, malignancy or not. Depending on, I mean, this depends on a lot of things, depending on the age of the patient, depending on the location of the lymph node, depending on the consistency of the lymph node, and depending on the risk factor, other risk factors like family history of malignancy. So many things are there. If you suspect malignancy, yes, or if you don't suspect malignancy, no. Okay, if you suspect malignancy, ideally, like you can go for some blood investigations. A full blood count will be more than enough, because you want to find out leukemia and lymphomas. A full blood count, maybe a chest X-ray and an ultrasound abdomen. Remember, more than 80 to 90% of the malignancies will be in the thorax and the abdomen only. More than 80 to 90% of the cancers will be in what? Thorax and abdomen. So if you do a chest CT and abdominal CT, 90% of the cancers can be diagnosed. So if you don't want this chest X-ray and ultrasound abdomen, you can go for even what? CT chest and CT abdomen also. Or if you are very extravagant, go for PET CT also. It's your wish, depending on the affordability of the patient. Okay. Now, if you are able to make a diagnosis, okay. So if your cancer suspicion is eliminated, if your suspicion is eliminated, if your suspicion of cancer is eliminated because you are suspecting cancer, it's eliminated. Now what we'll do, if the patient is having still suspicion for cancer, suspicion not eliminated yet, what you will do? The suspicion is not eliminated, you have to go for histology, which means you are going to go for biopsy. Remember, whenever you are having a suspicion for cancer, always do an excision biopsy, never do an FNAC. That's a gold standard rule. Whenever you have a suspicion for malignancy, never do a FNAC. FNAC is one of the useless tests if you have malignancy in your mind. Always go for biopsy, excision biopsy as a whole. That will be the gold standard investigation. Or alternatively, if you want, you can even go ahead with the bone marrow aspiration, because your cancer can be in the bone marrow also, right? So bone marrow aspiration. If you are not suspecting malignancy, then you can do viral serologies. Okay, if it's not suspected malignancy, or probably you can do a full blood count with CRP, ESR, basic investigations. A tuberculin sensitivity test, or probably a IGRA, that is interferon gamma release assay, or probably an ultrasound abdomen, along with a chest X-ray. So basic testing, or if you want to go, you can do a CT abdomen and chest also. If suspicion is eliminated means, then once again you are going to go for the same testing only from this arm also. So now you are going to see whether the test results are predictive or not. Predictive means any test results are making a diagnosis or not, or maybe I can say is able to make a diagnosis or not. If yes, then treat accordingly. If no, if the patient is still not having diagnosis, then you can try 14 days of empirical antibiotic therapy. Empirical antibiotic treatment with amoxicillin, clavulanic acid, or clindamycin, whatever antibiotic you know that you give, 14 days of empirical antibiotic therapy. If the lymph nodes regress, you just follow up the patient. No need to do anything else. Sometimes it could be a very, very benign node. You can just follow up the patient. If the antibiotic therapy doesn't work, the patient is having progression or no regression of the lymph node, it is persisting, or if it is progressing, then in this situation, once again, you have to go for excision biopsy. This is how a very basic structure, like if you study Harrison all, there will be very complicated flowcharts on how to evaluate a lymphadenopathy, but this is a very basic structure on how to evaluate a lymphadenopathy in the first place. Very simple, elegant flowchart. It will be very easy for you to understand how to evaluate a lymphadenopathy. That's why even though say gold standard for assessing lymphadenopathy is excision biopsy, but we don't do in all the patients. If you know a clear-cut diagnosis of why the patient is having lymphadenopathy, if patient is having ear discharge, having post-auricular nodes, why you want to do an excision biopsy there? It's very clear-cut diagnosis. Pharyngitis and submandibular nodes, very clear-cut cause. No need to do anything. Or if the patient is having cellulitis and inguinal nodes. So if you know, majority of the times it will be a clear-cut cause. You know what is the reason. So you need not even evaluate. If it's an unknown origin, or if you are suspecting something and the test is negative, then only you need to go for biopsy, depending on suspicion of malignancy, that too. Only if you suspect malignancy, you need to go for excision biopsy. Excision biopsy is the gold standard for any suspected malignant lymph nodes. So no, don't do FNAC at all. In this entire flowchart, I have not have given any FNAC at all in the first place. Isn't it? FNAC will not be there at all here.